something called Prolotherapy, another one category platelet-rich plasma, and then a third category stem cells. And hopefully helping patients decide, are any one of these injections right for me? Are all of them right for me? And really help, it's questions we get oftentimes in the consult room, help people determine whether this is something that might be an option for them. So again, just a quick repeat. The first option there that we mentioned was prolotherapy. Dr. Santana, if you want to take that one again.
Yeah, so prolotherapy, in essence, is we're using an external irritant, such as sugar or salt water, injecting it into the tissue that's injured, and we're trying to induce an inflammatory response in that tissue in order to start the healing cascade. As you can tell, it's fairly easy to do. It's really cheap and really safe because essentially we're just using a concentration of saline with sugar or salt.
Yeah. And that process stimulates your body to trigger the healing cascade through that irritant, which is essentially the same healing cascade that we trigger whether we're using platelet-rich plasma or stem cells as well, with the biggest difference is potency. Each of the injections stimulate that healing response in the native cells to heal themselves to a different level of potency, which with prolotherapy being the weakest. And so the next strongest option is something called platelet-rich plasma. And platelet-rich plasma comes from the patient themselves. So we do a blood draw, and then we centrifuge that blood to separate the things we don't want from the things that we do. We go under a vented hood and pipette out the stuff that we don't want, and then further concentrate the stuff that we do want. And then in our lab, we do a cell analysis of that end product to make sure that it has enough of the things that we do want and very little of the things that we don't want. In other words, making sure we have a very high quality, highly potent sample.
Yep. So it's a kind of, so like Dr. Nebby said, it's the same kind of algorithm that your body does in order to heal itself by using that inflammation. But the advantage of PRP is that because it's an internal stimulus for that inflammatory response versus an external stimulus from prolotherapy, that inflammatory response that you get from PRP is much stronger and more concentrated. And that's why with PRP, a lot of times when we do these treatments, we only do a treatment of one, versus prolotherapy, if you guys are familiar with it, usually you have to do a series of prolotherapy treatments consecutive times in order to kind of get a good response to build up that big inflammatory response.
And then the third of the category that we want to talk about is a much larger variability when you start talking about the term stem cells. So a lot of people just determine or use that word to mean a lot of different things. And tonight we'd really like to focus in on what each of those categories are, because they're very much different. So the first category I'll take is something called embryonic stem cells. So when you think about stem cells, and especially for me in the late 90s, early 2000s, there was a lot of research and energy that went around embryonic stem cells. So embryonic stem cells where an egg and a sperm come together, and they're meant to become an entire human body. Nothing of what we do here is embryonic stem cells, and very, very, very little research going on right now involves embryonic stem cells. Ethical reasons aside, those cells really had a difficulty in being controlled and ended up growing these abnormal tumors called teratomas, where, for example, if you're trying to grow a pancreas for somebody with diabetes, there would be teeth in the middle of that pancreas. So just not good. Difficult cells to control. Nothing what we do here involves embryonic stem cells, and really none of the research going into treating the types of disorders we treat use embryonic stem cells either. Another term that's similar to embryonic stem cells because it surrounds a baby is something called umbilical cord or amniotic fluid stem cells. I don't know if you want to touch base on those.
Why don't you take that enough?
Okay.
Autologous.
So the amniotic or embryonic cells prior to June of 2021 were things that could be used in the United States. Post June of 2021, FDA has reclassified these as a 351 product, which is essentially a drug, and they no longer can be used until they've gone through all the pathways that a drug has to go through. So those cells are no longer utilized in clinics like ours. The only utilization of those clinics within the United States is going to be under a investigational new drug FDA-approved clinical trial. So all things like umbilical cord cells, the amniotic fluid, the Wharton's jelly, and other amniotic tissue products are really no longer supposed to be used for orthopedic purposes in the United States. And everything we do here in the Michigan Center of Regenerative Medicine is within the scope of what is FDA compliant. So I think that takes us to the third category of cells, which are the types of cells that can be used. And we want to talk most exclusively about those. And that's autologous stem cells.
Yeah. So autologous stem cells are primarily, what us in regenerative medicine, in the orthopedic and interventional pain field is really focusing on. So we'll start with the bone marrow stem cells. So as the name implies, we get these mesenchymal stem cells directly from the bone marrow. So here in our lab, what we do is we harvest it from your pelvic bone, your iliac crest, and we again take it to the centrifuge in the lab, separate out the different parts of the bone marrow, and extract the stem cell component of that. And then we do our analysis and make sure we have the right quantity to do those that we needed for the procedure for the stem cells. And that's what we do to address orthopedic conditions with tendon issues, ligaments, joints, things like that. So that's the most common bone autologous stem cell procedure that we do here at Michigan Center for Regenerative Medicine. It's the most studied. It's the one that's been around the longest. And it's very safe, and it's been proven by a lot of research and also by our patients that we've seen here and treated with that it's very effective for treating these conditions. The other type of autologous cells that's gaining a lot of momentum and a lot of good outcomes are fat cells, because fat has a high concentration of cells per volume. So it's theorized that you get a lot more stem cells in that small volume of fat. Plus, fat's fairly easy to harvest. It's easier to harvest rather than going to the bone, into the bone marrow. So that way, and then you can inject it into different parts, and it works as well as any other stem cell would work. The one limitation that we have with using fat right now is that they still haven't come up with a straightforward method of extracting these fat cells that's within the guidelines set by the FDA. There are loopholes around it with research and research protocols that you can use in order to extract the fat cells from it, but using things like chemicals and other things like that to extract the fat cells is not allowed. So companies are trying to figure out a way to be able to extract the stem cells from fat without having to mechanically break down, I guess, those fat cells.
Yeah, so there's some rules when it comes to FDA and FDA compliance. There's three basic rules with what we're dealing. The cells need to be autologous, meaning they have to be coming from the patient. They have to be homologous in use, and that means that basically you have to be using for the same purpose that the cell have in the body. And everything we do here fits those two. And with orthopedics in general, both of those categories, both of those boxes are checked. The last being that they're minimally manipulated. It's a term that has a little bit of gray zone, but there is some that's very black and white. And in particular, if you add things like drugs to the cells, you're going beyond the minimal manipulation. And what Dr. Santana was alluding to is the fat cells, being the adipose cells, are different from the stem cells that are in the fat. And you really want to get those adipose cells out. And the best way to do that is by adding an enzyme that dissolves those fat cells. But that crosses the minimal manipulation barrier. So we can't do that in the United States. There are some good devices out there that use mechanical separation, filters, films, things like that. And we do have the option of using those. As it stands right now, I'm still in the bone marrow camp, in that I think bone marrow stem cells are better than the cells that we're able to, in an FDA compliant manner, isolate out of the fat. More and more studies are being done. We're now using a singular platform where we're comparing outcomes from different clinics, clinics like ours, and then there's other clinics that use adipose cells. And by using the same platform, we're able to compare the patients and their outcomes and see if a difference in what we inject makes a difference in outcomes. So far, early data doesn't show a big difference between the two types of systems. So
not enough for us to make the big leap and the big jump yet. But from what looks like, the data is starting to point that at some point it is, I think, like Dr. Navi is alluding to, this data registry that everyone's involved in. Once we kind of learn more about, fat cells versus bone marrow stem cells and where the application excels at, I think there's going to come to a point where we would know, like, hey, for a rotator cuff tear of this grade, fat cells will be a better option than bone marrow cells, versus your disc is going to be a better option for bone marrow stem cells. And I think it's going to come down to that kind of differentiation once we get more information and data out there.
Yep. And I think that is a nice transition to the next question I oftentimes get, and especially of my patients who are in a little bit older age brackets. Well, if I can't get umbilical cord cells in the United States, what about these clinics that are doing those sorts of treatments outside the United States? So I actually took a trip to Cancun and visited one of those clinics, and it was a very educational, eye-opening experience. The clinic is excellent. The types of treatments they're doing there are really exciting. I think there is a role for umbilical cord cells and what they can do just on their own, what they can be trained to do when you start talking about treating things like cancer, far outside of what Dr. Santa and I are doing here, strictly orthopedics treatments here at our office. But in this clinic, treating neurologic disease, treating autoimmune disease, treating heart disease, treating cancers. A lot of other applications can be had, both with autologous cells, as well as, meaning your own, as well as umbilical cord cells. Without getting down too much into the weeds, there's pros and cons between the different ones for whatever condition you're treating. Price becomes a big issue when you're starting to talk about doing these sorts of treatments. The price goes considerably up at these clinics with these umbilical cord cells because you have to do something called culture expand them. Whereas when we do the treatments here, we're taking your cells out and putting them right back in on the same day. We're not growing them in culture for weeks at a time. And the biggest question is, okay, well, what's right for me? What does it matter? And that's really where using this singular platform is going to help us. Getting clinics like the one I visited in Cancun, another one that's commonly referred to and publicized is in Panama, another one in Colombia, getting in touch with those clinicians, having them collaborate with us so we can compare outcomes and really truly find out which patient groups do better with what treatments. I think it's going to be extremely important. Right now, it's very much what's our experience, what does the preliminary data show, and there's a lot of conditions that do really well with prolotherapy.
Yep.
There's a lot of conditions that do really well with PRP, and there's a lot of conditions that do really well with only stem cells. So I think one of the things we do a really nice job of here in the clinic is helping our patients know whether, okay, prolotherapy is probably going to give me a 30-40% chance of getting a good outcome, and I'm going to need 4 or 5 injections of those. PRP is going to get a 70% chance of outcome, and stem cells is going to be a 75. Well, for that small difference between 70 and 75, the big cost difference, let's just go with a PRP. And we make that recommendation quite often when we have conditions where we think PRP is going to be sufficient for you, versus the conditions that are more advanced, less blood flow, and maybe we can go into a little bit how we decide those sort of treatments.
Yeah, I mean, because like so there's a lot of when I counsel patients about what treatments to go for, you're right. There's a lot of factors that come into that. Financial factors is always the big issue because these procedures are not covered by insurance, so they're all out of pocket. So it's a big cost. And when kind of talking about these procedures, always you kind of have to put like a cost benefit ratio with the cost actually having dollar signs and benefit with your outcomes. So when I go about this algorithm with the patients, for me, the simplest way I can kind of explain it to patients is that usually for less severe conditions such as ligament tears, partial tendon tears, non-weight bearing joints, mild degree of arthritis in the non-weight bearing joints, probably PRP is going to do a very good job for those types of things. It also means that stem cells are also going to do a great job for those things too, but from what's the minimum procedure I could do at the lowest cost, it's going to give you a good outcome, then I'm going to present PRP as the option for you. If it's going to be more of a weight-bearing joint or a higher degree osteoarthritis or a high mobile area, dynamic area like your spine or your pelvis, where you have a lot of motion in there and the injury is more chronic, taking all these considerations and stuff like that, then that's how I'd recommend stem cells. There's some conditions where now, knowing what we know over the years that we've doing this, knowing our outcomes are with PRP versus stem cells, I'm leaning more heavily with stem cells for conditions that I know that stem cells are really just going to work well for. Some things like the spine. The spine is a very complex structure. It's a weight-bearing joint. It's very dynamic. It's one of these areas where when I go there, I only want to treat it once and be done and fix it right away. It's not the place where I want to be able to return and fix again down the line if I don't need to. So usually for spinal conditions, I would usually say that stem cells will be the best option. It's very rarely where I would say PRP is an option for spines, unless maybe if you're a younger person, who very healthy, has very minor type stuff going on in there, then I think that's where PRP would probably have a role. But for the patients that we see here, from our demographics that we see and from the outcomes that we've seen before, I think stem cells will be what I would recommend for spinal issues.
Yep.
What about you?
No, it's the same. I echo those exact same comments. Times where I consider PRP as being sufficient is if it's a simple annular tear in a disc, very little degeneration, very little herniation, or if it's non-disc related spinal issues, ligament strains, ligament tears, soft tissue strains, SI joints, stuff like that. PRP works extremely well for, almost equally to bone marrow. But to sum it up, a bone marrow stem cell or a stem cell procedure is always going to give a better result than a PRP. But that might just be fractional percentages, in which case it's not worth the value, versus other conditions are dramatically better with a stem cell than with a PRP, cost aside.
Yeah, and not just the cost too, like just to be able to undergo a stem cell procedure too, like we still have to harvest the stem cells from your bone marrow. So there's still that added procedure on top of that as well. So again, something to take consideration too. But, in a vacuum, if you ask me, prolotherapy, PRP, or stem cells, what's the best one you've got? I would say stem cells hands down all the time.
Yep.
Right?
Yep. Every time.
Yep.
So we like to try to keep these about 20 minutes, not too terribly long. Maybe open up if anybody has any questions specific to themselves or to loved ones. Feel free to type in any of those questions. I think we did a decent job of kind of the high level overview, but biggest pro con difference is potency. The stronger procedure you use, the better outcome you're going to get.
Yeah. The good thing is like they all work, and they all work really well. It just so happens that the prolotherapy works well, PRP works better, and stem cells work best.
The best. Yep.
And depending on the application, and then I think that's where our experience comes in. When you come in for an evaluation, for a consultation, we kind of take a look at all of these things, and not just your diagnosis, what your symptoms are, what your goals are. If your goals are, we kind of try and tailor treatments to what those are too, and it kind of helps together make the right decision for you. Yep. So we like to pride ourselves in doing it. All right. Here's a question from Chris. Has any of these procedures been used for arthritis in the knee?
Yeah.
Yes, all of them. I would say here in our office, knees are probably the most common body part that we treat here, followed by spine, right? Did you think?
Yep.
Yeah.
Yeah.
Okay.
I think knee, spine, shoulder is our third.
Yeah. Yeah. Great. All right. Let's see. All right. Well, if there's no other questions, thanks again for joining us tonight. I hope this has been very informative. Again, we want this to be a conversation starter. So if you're looking into the path of getting regenerative medicine treatments, at least something to kind of think about or start your research, trying to figure out what the best options are for you, whether it's going to be us or someone else. I want you to start thinking about these questions. But if you are, then let us know. Give us a call here at the Michigan Center for Regenerative Medicine. Our number here is 248-216-1008. That's 248-216-1008.
Yep. Thanks, everybody. And hope you all have a good night.
Good night.